to please deliver a talk.
Good morning, sir. Good afternoon, everyone. I'll be discussing the important aspects of neuraxial anesthesia today. Spinal, epidural, and caudal blocks, they are together referred to as the central neuraxial blocks. There are significant differences in their techniques and the drugs used. However, all of them, they produce a combination of sympathetic, sensory, and motor blockade. In spinal anesthesia, a small amount of drug produces a rapid, profound, and finite sensory analgesia, while epidural block progresses slowly and it's commonly prolonged using a catheter and large amount of local anesthetics they are used. In combined spinal epidural techniques, it adds flexibility to the level of analgesia and anesthesia provided to the patient. On the lateral view of the vertebral column, 4 curves they are seen. Note the thoracic kyphosis and the lumbar lordosis. Spinal cord terminates at the level of L1 in adults, while at the level of L3 in children, while dural sac, it terminates at the level of S2. Spinal canal contains the spinal cord with its coverings, the meninges, the pia mater, which is adherent to the spinal cord, and then the arachnoid mater and the dura mater. At each vertebral level, paired spinal nerves, they exit the central nervous system. In all, there are 31 pairs of spinal nerves. And in the anatomy of the, word about the anatomy of the lumbar vertebra, it is, the body is massive kidney shaped upon axial view. And the foramen is triangular. The spinous processes, they are short and sturdy. And the line drawn between the highest points of iliac crest, it crosses the body of L4 or L4-5 interspace. The thoracic vertebra, the foramen is smaller and more circular. While the spinous processes, they are long and they slope posterior-inferiorly, with the tip extending to the level of vertebral body below. With the arms placed at the sides, T7 is usually at the same level as the inferior angle of scapula. So this is very significant in case of placing the thoracic epidurals. The needle has to be directed more in the capsular direction. The vertebral bodies, they are stabilized by 5 ligaments that increase in size between the cervical and the lumbar vertebrae. The supraspinous ligament runs from the sacrum to the T7, and above T7 it runs as ligamentum nuchae and attaches to the occipital protuberance. The interspinous ligament attaches between the spinous processes and blends posteriorly with the supraspinous ligament and anteriorly with the ligamentum flavum. Ligamentum flavum is a tough wedge-shaped ligament composed of elastin, and it is thickest in the midline, measuring 3 to 5 millimeters at the L2-3 interspace. So midline insertion is least likely, midline insertion of epidural needle is least likely to cause unintended meningeal puncture. So what are the boundaries of epidural space? It is bounded anteriorly by the posterior longitudinal ligaments, laterally by the pedicles. Here we can see the boundaries of the epidural space. So it is bounded anteriorly by the posterior longitudinal ligaments, laterally by the pedicles and the intervertebral foramen, and posteriorly by the ligamentum flavum. In the surface anatomy, C7 is the most prominent process in the neck, and T7 corresponds to the inferior angle of the scapula, while L4 is at the level of the line connecting the iliac crests, and S2 is at the level of line connecting the posterior superior iliac spines. The indications of the neuraxial anesthesia, almost all the surgeries of the lower abdomen and the lower limb can be done under neuraxial blocks, which include orthopedic surgeries, major hip knee surgeries, cesarean sections, and prostate surgeries. And also in post-operative analgesia for thoracic epidurals and lumbar epidurals can be placed. And epidurals are also very useful in chronic pain management. Important contraindications in the absolute contraindications are few, which include patient refusal, infection at the site of injection, any allergy to the drug to be administered, raised ICT, and uncooperative patients. Whereas there are various relative contraindications, so which can be individualized depending upon the severity of disease in the patient. In the surface anatomy, note that the thoracic nerves, they supply almost whole of the thorax and the abdomen, whereas the lower limb is supplied by the lumbar and the sacral nerves. Cardiac accelerator fibers arise from T1 to T4, and the blockade produces severe bradycardia and decreased contractility. Whereas T5 to L1 dermatomes, they include the vasomotor fibers and the sympathetic outflow. And the most dependent part in the supine position is T4 to T8. It is important for hyperbaric solutions because they tend to settle in this area. For upper abdominal surgery and cesarean section, dermatomal level of T4 or T5 is required. While for appendicectomies, gynecological and intestinal procedures, T6, T8 sensory blockade is needed. And for vaginal delivery, TURP, T10 level of block is required. For lower limb surgery, L1 sensory blockade and L2 for foot and ankle surgery. The principal site of action for neuraxial blockade is believed to be the nerve root. The local anesthetics, they bind to the nerve tissues and disrupt the neural transmission. The speed depends on the size, surface area, and degree of myelination of the nerve fibers exposed to the local anesthetics. And the sequence of the blockade is also because of the block of the different nerve fibers in different time intervals. First and foremost are blocked to be the preganglionic B fibers, which cause sympathetic block with vasodilation. Then is the loss of temperature, that is the loss to the cold sensation, and that is by the blockade of the C fibers. Then is the blockade of the pain fibers by the A beta fibers. Then loss of proprioception, then loss of pressure, and finally, last to be blocked are the A alpha fibers for motor blockade. Sympathetic blockade is usually 2 to 6 segments higher than the sensory block, while motor blockade is 2 segments lower than the sensory block. This distinction is not very apparent during epidural anesthesia. So what is differential sensory block? So there is an observed difference in the peak block height. For example, the level of anesthesia to cold sensation is 1 to 2 segments higher than the level of pinprick anesthesia, which in turn is 1 to 2 segments higher than the level of touch anesthesia. So this is known as the differential sensory block. So what do you mean by differential block? By using relatively dilute concentrations of local anesthetics in epidural blocks combined with the opiate, it can the epidural can block the smaller sympathetic and sensory fibers while sparing the larger motor fibers. So the patient is even ambulatory. In the segmental block, a local anesthetic is not spread readily as in spinal anesthesia. A well-defined band of anesthesia at a certain nerve roots without those above and below can be blocked. It can be achieved with epidural techniques. So what is the fate of anesthetic solutions injected epidurally? So after the longitudinal spread in the epidural space, there is leakage by vascular absorption, leakage through the intervertebral foramina, and diffusion through the dural root sleeves and diffusion through the dura mater into the CSF. There are 4 P's for administration of the neuraxial anesthesia are preparation, position, projection, and puncture. In preparation, informed consent, appropriate monitors, airway and resuscitation equipment, it is mandatory. Intravenous access should be secured and all necessary medication should be drawn up prior to positioning. Spinal needles, they fall into 2 main categories. Those that cut the dura, which include Quincke Babcock needle, and those with the conical tip, which include Whittaker and Sprotte needle. The usual site in adults is L34 or L45, while in infants it's L45. And the line joining the iliac crest, this crosses the body of L4 or L45 space. The two most common positions are sitting and the lateral decubitus position. The assistant must keep the patient from swaying and curve the back of the patient like a C so that the intervertebral spaces, they are opened up. In the lateral decubitus position, it needs to be parallel to the edge of the bed and the legs are flexed up to the abdomen. So this slide again showing the surface landmarks. Proper positioning is key to making the spinal anesthetic very quick and successful. After correct positioning, midline should be palpated and the interspace is identified depending upon where the needle is to be inserted. And after skin is cleaned and under all aseptic conditions, a small wheel of local anesthetic is injected in the skin at the level of block. 2 main approaches, midline approach or the paramedian approach. In the midline approach, all the structures are pierced, starting from skin, subcutaneous fat, supraspinous ligament, interspinous ligament, ligamentum flavum, then dura mater, subdural space, arachnoid mater, and then you reach the subarachnoid space. While in the paramedian approach, you bypass the supraspinous and interspinous ligaments. Needle is advanced with bevel parallel to the midline. With the advancement of the needle, with increasing resistance, 2 pops are felt. First is the penetration of ligamentum flavum, and second is the penetration of dura arachnoid membrane. This stellate is then removed and CSF should appear at the needle hub. And anesthetic dose is injected at the rate of approximately 0.2 ml per second. In case CSF is not, we do not get the flow of CSF, you give the clockwise rotation, 90-degree clockwise and rotation to the needle so that the full bevel enters the subarachnoid space. In the paramedian approach, is used in the setting of calcified interspinous ligament or where there is difficulty in flexing the spine. Needle is inserted 1 centimeter lateral and inferior to the superior spinous process of the desired level, and angle is around 20 to 25 degrees towards the midline. The ligamentum flavum is usually the first resistance which is identified. So what are the important factors affecting the block height of spinal anesthesia? They can be drug factors, patient factors, and the procedure factors. The dose of the local anesthetic and the baricity of the drug, they are the important drug factors. While advanced age, pregnancy, and intra-abdominal pressure of the obese patients, they are the patient factors which determine the height. While the position and the level of injection, they are the most important procedure factors affecting the height of spinal anesthesia. Usually hyperbaric bupivacaine we use for spinal anesthesia, and the various additives like fentanyl, clonidine, dexmedetomidine, neostigmine, epinephrine, they are used as adjuvants to intrathecal local anesthetics, and all of them, they decrease the onset time as well as they prolong the duration of analgesia. So the projection and puncture in case of epidural block, the first and foremost is identify the midline. Insert the epidural needle into the supraspinous ligament and the interspinous ligament, and then remove the stellate and attach the LOR syringe, loss of resistance syringe. So air or saline is commonly used to detect the epidural space. Ligamentum flavum is identified as a tough structure with increased resistance. In the lumbar area, the depth of skin to ligamentum flavum is approximately 4 cm for most adults. 80% of the adults have a skin to ligamentum flavum depth of 3.5 to 6 centimeters. And the average thickness is 5 to 6 millimeters at this level. Controlling the needle is very important to avoid a dural puncture. In the thoracic area, it's all the more important to avoid dural puncture and risk of spinal cord injury. So these are the epidural needles available. Commonly used 18 gauge 2 needle is used. This is the LOR syringe. So negative pressure techniques include hanging drop sign, and disappearance of techniques include the loss of resistance to air or saline. Once the space is identified, advance the needle further 1 to 2 millimeters and insert the catheter 4 to 6 centimeter into the epidural space. To identify any inadvertent venous cannulation or subarachnoid placement, test dose should always be given. It consists of 3 ml of 2% preservative-free lignocaine with 1-2 lakh epinephrine. Aspiration before each injection and incremental dosing of 5 ml every 5 minutes that should be performed to avoid the intrathecal or intravascular placement of local anesthetics. So what are the principal determinants of dosage? Volume of anesthetic solution required for epidural block depends upon the age of the patient, the segment factor, the height of the patient, selection of the interspace, whether it is a lumbar or lower thoracic epidural. In case of lumbar, approximately 2 to 2.5 ml of drug is required for each segment block, while in the thoracic level, around 1.5 ml of drug is required for the block. And then the clinical modifying factors include the obstetric patients, in obese patients, patients with abdominal distension, there is 30% dose reduction. And extradural factors and compliance of the epidural space, that's also important. These are the various local anesthetics which are commonly used for epidural blockade. What are the physiological effects of neuraxial anesthesia? These are very important. The physiological responses of neuraxial block result from the decreased sympathetic tone or unopposed parasympathetic tone, or both. The physiological effects of epidural, they are similar to those of spinal anesthesia, except that the local anesthetic level may reach the concentrations enough to produce the systemic effects on their own. That is the last, local anesthetic systemic toxicity. Cardiovascular system, decreases in blood pressure and heart rate can occur, which is much more profound if the block is up to T1 to T4 levels. And what is dissolved gyrus reflex? In patients with hypovolemia, decreased preload, profound vasodilation, they can activate the mechanoreceptors in heart, and profound bradycardia with hypotension can be seen. In respiratory system, during there can be decrease in the vital capacity, which is compensated by the unaltered function of the diaphragm by the phrenic nerve. And it is respiratory arrest can occur due to hypoperfusion of the respiratory centers in the brainstem. Management is by the administration of oxygen. Urinary system, there can be urinary retention. And there is contracted gut and active paralysis, and which can result in nausea and vomiting. Spinal anesthesia induced hypotension, that it can decrease the cerebral blood flow and in elderly patients. Surgical trauma produces a systemic neuroendocrine stress response, and there is increased secretion of ACTH, cortisol, epinephrine, norepinephrine, vasopressin levels, as well as activation of the renin-angiotensin aldosterone system. Neuraxial blockade can partially suppress this neuroendocrine stress response, which decreases the postoperative morbidity. Important complications include neurological complications include, they occur very rarely, but they can occur: paraplegia, cauda equina syndrome, arachnoiditis, post-dural puncture headache, transient neurological symptoms. And cardiovascular, they are the potentiation of the physiological effects include hypotension, bradycardia, cardiac arrest, respiratory depression, infection, backache, nausea, vomiting, urinary retention, pruritus, and shivering. T1 to T4 involvement can lead to severe bradycardia and asystole. Even nausea, vomiting can be associated in up to 20% of the patients, and atropine is effective in treating nausea as well as bradycardia. What are the predictors of hypotension? Low intravascular volume in case of hypovolemia due to external loss by trauma and dehydration. Sensory block higher than level of T5. Age more than 40 years. Combined spinal and general anesthesia. Dural puncture between L2, 3 and above. Emergency surgery. Patients with uncontrolled hypertension and underlying autonomic dysfunction. Treatment is 100% oxygen, elevation of leg, head down position, crystalloids, colloids, sympathomimetics, epinephrine, phenylephrine, ephedrine, and mefentrine. High spinal, then the spread of local anesthetic is above T4 level, and total spinal anesthesia can occur with intracranial spread of local anesthetic, resulting in loss of consciousness. Management is by the maintenance of ABC, airway, breathing, circulation, and continue to ventilate till the block wears off. As the block recedes, the patient regains consciousness, followed by breathing and movement of arms and legs. So post-dural puncture headache is a very important potential expected complication. It initiates it is the compensatory, response, of the intracerebral vasodilation to offset the reduction of the intracranial pressure. The symptoms begin in 24 to 72 hours of the procedure, and it is characterized by bifrontal or occipital headache, which is usually worse in the upright posture and worsens on coughing, straining, associated with nausea, photophobia, and diplopia. Treatment is patient is made supine, adequate hydration, NSAIDs with and without caffeine. Epidural blood patch is the definitive therapy in refractory cases. So these are the various variables which influence the post-spinal puncture headache. More in younger patients, in females, and more with the larger gauge needles, less with pencil point needles, more in pregnant patients, more with multiple punctures. These are the specific complications with epidural blocks. There can be inadvertent dural puncture, total subarachnoid block, or subdural injection, and there can be catheter-related complications. So neuraxial anesthesia has to be modified in patients receiving thromboprophylaxis. So the drug modifications of the heparin and the low molecular weight heparin, that has to be done before attempting neuraxial blocks. Then lastly, few slides of caudal anesthesia. The sacral foramina, firstly the anatomy, they together form the sacral canal, and the lower opening is called the sacral hiatus, which is formed by failure of the laminae of the S5 and part of the S4 to fuse in the midline. It's an inverted V-shaped bony defect which is covered by the sacrococcygeal ligament. So posterior superior iliac spines and the sacral cornu, they form a equilateral triangle. It's commonly used in pediatric age groups. Indications include mostly surgical procedures of the lower part of the body below the umbilicus, inguinal hernia repair, urinary and digestive tract surgery, orthopedic procedures on the lower extremities. So three main positions. The preferable position is the lateral decubitus position. Draw an equilateral triangle, the base of which is the distance between the posterior superior iliac spines, and the apex will point inferiorly over the sacral hiatus. The sacral hiatus is located by palpating the coccyx and then sliding the palpating finger in the capsular direction until a depression in the skin is felt. After it is identified, the index and the middle fingers of the palpating hand, they are placed on the sacral cornua, and caudal needle is inserted at an angle of 45 degrees to the sacrum. While advancing the needle, a decrease in resistance to needle insertion should be appreciated and needle enters the caudal canal. The needle is advanced until the bone is contacted and then slightly withdrawn and is redirected so that angle of insertion relative to the skin surface is decreased. Now the needle is advanced approximately 1 to 2 centimeters in the caudal canal. Further advance is not attempted. Dosage by the scheme of Armitage, it still remains the most dependable. With 0.5 ml per kg, all circular dermatomes are blocked, and with the increased dose of 1.25 ml per kg, the upper limit of anesthesia is at least mid-thoracic. Complications: intravascular intraosseous injection, dural puncture, perforation of rectum, sepsis, urinary retention, and hematoma. So finally, what is the role? The neuroaxial anesthesia has a very important role in anesthesia practice. The neuraxial blocks, they decrease the post-operative morbidity. They reduce the incidence of venous thrombosis and pulmonary embolism. They blunt the neuroendocrine stress response, decrease the cardiac complications in high-risk patients, bleeding and transfusion requirements. So various studies have shown they reduce the risk of pneumonia and respiratory depression following the upper abdominal and thoracic surgery in patients with chronic lung disease. And they allow earlier return of gastrointestinal functions following surgeries. And they help in better post-operative pain control. So thank you. I'm very thankful to the organizing team for involving me in this academic program. And any queries and questions, they're welcome. Thank you.
Thank you, Dr. Brinda. And you have very nicely covered the basics of neuraxial anesthesia, which a resident is supposed to know and answer most of the questions. And there doesn't seem to be any questions in the chat box. There doesn't seem to be any questions in the chat box for you. So just one question which is usually asked by the examiners is, what is the cause of negative pressure in the epidural space? Probably the residents will gain, because these are normal questions which an examiner usually asks them, why is there a negative pressure in an epidural space? So if you can throw some light on
negative pressure is because most likely due to it is a closed space actually. If we, it's also recommended in some of the studies that you directly, reach the epidural and then only you remove the reach the ligamentum flavum before you remove the stellate. If you remove the stellate earlier, like in the supraspinous or the interspinous ligament, there will be more chances of falsely loss of resistance. So it is a closed space, and the chance of false loss of resistance, that is very less. So absolutely closed space, and that is why it is a negative pressure.
Ma'am, there is a question for you. That is, kindly explain heart rate and BP changes and other signs and symptoms to look after giving test dose in epidural in awake and in intubated patient.
Okay. So usually, the first is just to know about whether the if accidentally intrathecal placement or intravascular placement we do. In the intubated patients also, if there is 20% increase in the heart rate or blood pressure, that indicates the intravascular administration of the epinephrine. So that is approximately 15 micrograms of epinephrine, 5 microgram per ml, that is given as the test dose. So that definitely produces a 20% increase in heart rate and blood pressure, whether the patient is intubated or even if the patient is awake, if there are no external stimulus. But this is, deceptive in laboring patients. So that is why the role of test dose decreases in the patients in labor. And the other thing is intrathecal. It is mainly if we give it before this thing spinal independently, then only we get to know whether the sensory block that has occurred with lignocaine or not. Otherwise, it's very difficult to know about this thing intrathecal. If it's intrathecal, we can have a sudden fall in blood pressure if totally the drug goes intrathecal. But as far as sensory block is if we have given, like I am talking about combined spinal epidural. If we've given spinal along with, then it's very difficult to know about the intrathecal spread. If we are giving just the epidural block, then definitely we get to know about the intrathecal spread also in the first 2-3 minutes.
Ma'am, there is another question that how much is the maximum dose of lignocaine, bupivacaine or ropivacaine we can give in the epidural anesthesia?
So the dose that remains the same, the safe dose that remains the same for the local anesthetic as we give in the, the blocks or the epidural. So safe dose remains like 2.5 milligram per kg for bupivacaine, and we can increase it to 3 mg per kg for ropivacaine. And the same is with lignocaine, and the lignocaine with ADR that increases up to 7 mg per kg we can give. The plain lignocaine, the doses again decrease. The main important thing is for epidural, just to decrease the, any kind of complications, test dose should always be given, even before giving any kind of top up, because catheter can migrate later on. And secondly, the incremental doses of 5 ml after, every 5 minutes, that should be followed. Rather than giving straight away 15 ml or 20 ml, the dosing should be incremental in the boluses of 5 ml. So that if any inadvertent, intrathecal or intravascular placement is there, so we can, get to know very early.
Yes, ma'am. Thank you very much. There doesn't seem to be any more questions from in the chat box, and you have rightly covered the basics of neuraxial anesthesia and what a resident is supposed to know. So thank you very much, ma'am.
Thank you, sir.
Now I'll be inviting the second speaker who will be talking about, she is Dr. Uma Hariharan, who works as an associate professor in Department of Anesthesia at Ram Manohar Lohia Hospital, New Delhi. And she is a fellow of Indian College of Anesthesiology Hall of Fame Award in 2018, Best DNB Student Award. She has a Best Paper Presentation Award from ISCCPM, Poster Awards from ISA Delhi in 2011, editorial board member of JOCP IGCA, IGA, AOJ, ERHM. She is a reviewer from many